Neurological examination should start where neurology starts, and that's the head, and then move down the neck, down the shoulder, and into the hand and wrist. And so what I thought I'd do right now is to show you how to start with a neck examination and then move on down. So first I would normally ask the patient to go ahead and flex her neck all the way, bend down as far as you can, and then bend all the way back and look towards the ceiling. And then bring your head back to neutral, and then rotate that way as far as you can go. Rotate this way as far as you can go, and then back to neutral. And all you're doing is examining the full range of motion of the neck and making sure that there's no deficits there. At this point now, I'd start to provoke the nerves coming out of the neck by doing certain maneuvers of compression, including bend your ear down towards your shoulder, and then the opposite way. And I'm just looking to see if there's any area of, or exacerbation of any symptoms with that maneuver, which would close down the foramina on either side of the neck. At this point, I'd probably put a little, ask the patient to flex their head slightly and put a little pressure down on the head and see if that reproduces any symptoms in the upper extremity, any tingling, any radicular signs, that sort of thing. I'd do a full Lermit's sign, which is to ask the patient to flex their neck all the way down and hold that for a few seconds. What that's doing in someone who has spinal cord entrapment is to flex the cord over the vertebrae, and it may produce paresthesias either in the upper extremities or the lower extremities or both. And then I'd ask her to bring her head up and then to the opposite side of the affected extremity, what's called the Sperling's maneuver, and up a little bit more, Sperling's maneuver, which would compress the foramina and bring out signs of radiculopathy. Next thing I'd do is to look to see if there was any vascular compromise of the upper extremity, and this would be pertaining to something like thoracic outlet syndrome, which can be pre-existent in up to 20% of your patients with carpal tunnel syndrome. So I begin by feeling the pulse with the arm in just a neutral position, and then bringing the arm up in the so-called Wright's maneuver, 90 degrees abduction at the shoulder, 90 degrees at the elbow, continuing to feel the pulse the entire time. If there's any diminution in the pulse or any reproduction of paresthesias, that would be considered a positive sign. Then I then ask the patient to stand up, bring the arm out to the side, and then ask the patient to look the opposite way and then up towards the ceiling. This is the so-called Adson's maneuver. And again, I'm looking for any loss of pulse or any reproduction of paresthesias in the upper extremity. You can hyper-extend the arm somewhat to bring that out. What that's doing is closing down the outlet. Some people disagree with that and actually would ask the patient to bring their chin down to this side, all the way down and rotate, and repeat the test. I would ask them in either one of these maneuvers to take a full breath all the way in, hold it, and out, and see if raising the lung, raising the height of the pleura, further compromises the thoracic outlet. So that would complete the majority of your examination of the neck. If you're really concentrating on thoracic outlet, you might do one other test, which is called a Roos test. Bring your other arm up as well, if you would, and grasp and release several times with both hands. What we're doing here, and bring both arms up, what we're doing here is asking the patient to utilize the small muscles of the hand. And in someone who has compromised blood flow to the upper extremity, the hand would quickly become clumsy, and she would feel awkward and perhaps start to feel paresthesias in both hands. All right, and then if you would bring your arms back down, turn that way if you would. Costoclavicular maneuver would be to pull down on both arms. I'm now compromising the difference between the clavicle and the first rib, or the distance between the clavicle and the first rib by doing that. Again, provoking paresthesias. Be careful when you're doing this not to compress the ulnar nerve at the side, because that might give you a falsely positive examination. Lastly, if you turn that way, you're going to look at the general condition of the shoulder, see whether there's any atrophy, any periscapular atrophy, any atrophy of the deltoid or the arm muscles, and just sort of a general condition of the spine. All right, at this point in time, turn around again, I'd do a motor examination of the upper extremity. I'd start with the patient standing, and then once you've examined the periscapular muscles and the shoulder muscles, I'd then work my way down the arm. We're going to do this in nerve segments starting with C5, C6, 7, 8, and 1, each of the levels of the brachial plexus. And this is, again, a general examination of the upper extremity. So, beginning with the deltoid, arm up, hold it at her side, resist me. I'm going to push down, okay, with the arm in this position, turn the thumb down towards the floor. This is testing the supraspinatus and the external rotators of the arm. I'm going to ask her to lift her arm up towards the ceiling, and I'm resisting, getting a general flavor of the strength of the rotator cuff. Bring the arm back down to the side and ask her at the same time to bring the arm towards the midline. Go ahead and pull your arm across. And I'm both examining and visualizing the pectoralis. And we have full strength in those muscles. Resist me again, coming down to the side, and I'm both examining and visually inspecting the latissimus for strength. Everything's fine there. Again, turn that way if you would. Looking at the back, bring the scapula towards themselves. Yep. And we're looking at our rhomboid muscles here. I'm going to resist me as I push forward. Okay. Shrug your shoulders and hold them up. And spinoaccessory trapezius. And then finally bring your arms up in front and look at the alignment of the two scapulae. Look at the distance from the central line, and you can actually measure the distance from the vertebral processes to the scapular border and see that they're equal. In conditions such as impingement syndrome, in conditions such as nerve injury, oftentimes there will be scapular dyskinesia, which will allow one of the scapula to rotate out further or sometimes wing, and you'll see it in this exam. Winging might be indicative of either trapezius weakness or serratus anterior weakness, which can cause the shoulder blade to actually drift out or sometimes rotate on the thorax. Okay, bring your arms down. That maneuver can be accentuated by asking the patient to push against a wall as well. Okay, come on back down. So first I'm going to ask Joy again to flex her elbow, and I'm looking here at the brachioradialis and resisting her. Okay, that's C6. At this point in time, I'm going to ask her to extend the wrist and hold it. C6 again, wrist extension. And if you think about it, C6 is wrist extension, C7 is MP extension, and then C8T1 is IP extension. And that's just a useful mnemonic, C6, 7, and 1. Helps you to recall those muscular levels. So again, C6, wrist extension, hold your wrist back. Okay, now you can go right to finger extension. And really where you want to test is just past the MP joints, because you're looking to test the long extensors of the digits and not so much the extrinsics, which are out here. Okay, with this position, you can go ahead quickly and test intrinsic function as well. Fan your digits and hold them. And bring your thumb up as well and hold that. You're both testing the muscle, which in this case is the extensor pollicis longus, and the level, which is C7, C8. Importantly, sometimes in problems about the posterior interosseous nerve or the radial nerve, you'll need to discriminate between radial wrist extension and ulnar wrist extension. So it's not a bad idea to place the person's hand for the muscle that you want to test and then hold it there and resist. And you can see standing out the extensor carpi ulnaris, okay, which is one of the last muscles down the line of the posterior interosseous nerve, and a C7, C8 innervated muscle. Okay, we're going to flip over now. With any of these maneuvers, you want to be looking for any obvious atrophy of the forearm as well. And as you can see here, there's normal contour of both Henry's wide, the extensor muscles, and the flexor pronator mass. It's very important to look for atrophy here. And while you're in this position, I'm going to ask the person to rotate her arm that way. So go ahead, rotate that, and resist me as I try to rotate it back. Pronator is being tested right now. Now keep it there. Now try to rotate your hand back into position. Keep your hand there and resist their ability to supinate. Okay, you're testing both supinator and biceps with that maneuver. Flex the wrist down, hold it there, and pull against me. I'm testing both flexor carpi radialis and ulnaris, and I want to feel with my other hand as I do that. Relax. And then each of the fingers have to be tested in turn. And you're going to ask the patient to go ahead and flex each finger one by one. And you're testing the flexor superficialis muscle. You can do that against resistance. Go ahead and try that again with your middle finger. She's got normal strength of flexor sublimis. And then now to test your profundus, you have to do them all at once. Go ahead and bend down the tips. And you can help them by holding down the PIP joint and then manually resisting their ability to flex the tips of the fingers. Now, because the profundus is both dually innervated by the median nerve and the ulnar nerve, on occasion you'll want to test both sides independently. Go ahead and bend your fingers down. And I'm pulling against both the ulnar innervated profundi and the median innervated profundi to get a sense if there's any discrepancy there. That can be important on ulnar neuropathies or sometimes high median neuropathies, which can affect, again, the profundus muscles in the forearm. While you're here, go ahead and flex the thumb down and hold it. Okay? And then we're going to work towards an intrinsic examination of the hand. I've already asked her to fan her digits and hold it. And here we're going to look for any obvious atrophy of the abductor digiti minimi or the first dorsoneuroosseous adductor. I'm going to ask her to post her thumb. And it's helpful to position the person's hand where you want it and ask them to hold it there. So go ahead and hold it there as I resist. And we're looking at both the contour and the bulk of the abductor, short abductor of the thumb, short flexor of the thumb, and then bring your thumb across to your little finger. You can test, again, abduction power and adductor power. Bring your thumb across like that, adductor power of the thumb. Another quick way to test these, to gain our intrinsic strength, is to ask her to go ahead and pinch that like it's a key and observe the posture of her thumb. Most people, when they're pinching like this, will keep the thumb tips fairly straight, and you can look right away at the first dorsal neuroosseous. A sure sign of ulnar nerve entrapment is when you've got hollowing atrophy at this point here. To test for ulnar weakness, you ask her to do that simultaneously with both hands. Go ahead and grasp and pinch on both sides and pull against each other. Now, a person's going to naturally go into their power pinch pose, which is straight at the eyepiece on both sides, and you're looking at first dorsal neuroosseous. If Joy was to flex her thumb like that on one side and keep it straight on the other, you'd suspect that, in fact, there was marked weakness of the first dorsal neuroosseous here, causing her to use her long flexor of the thumb and her long flexor of her index finger rather than the intrinsics of her hand to achieve the same degree of strength. That's called a positive Froment sign. If, when asking a patient to abduct, they do fine, but when they're adducting, the small finger stays out in left field like that, it's because of an intrinsic muscle imbalance, interosseous muscle weakness, that's preventing her from adducting her small finger. We see that on occasion when an ulnar nerve is recovering, and it's already re-innervated the abductor digiti minimi, but has failed to turn around the horn and start to innervate the smaller interosseous muscles of the hand. So that's a sure sign of ulnar nerve weakness, and sometimes, paradoxically, a good sign when the ulnar nerve is recovering after a high-level injury. After we've tested motor, we want to go to a sensory examination, and I'm going to go through a rather cursory sensory examination to make sure we find all the autogenous zones of the sensory levels. C5 would be directly over the deltoid, okay, and you want to check posterior deltoid, middle, and anterior deltoid sensory dermatomes. Why is that important? Well, the axillary nerve, of course, comes through beneath the axilla, through the quadrilateral space, and then around. So in cases of axillary nerve recovery, you may have sensory return posteriorly before you get it in the middle or anterior. Similarly, you may have motor return of your posterior deltoid before your middle or anterior. So it's very important in your deltoid to check all three components. So that's C5. Don't be confused by the C4 region, which can come down here, and occasionally intercostal brachial nerves, which can affect your sensory examination here. The autonomous zone of C5 is really about a orange-sized area right here over the deltoid, not right over the crest of the deltoid at the acromion, but about 3 or 4 finger breadths down. C5. C6 autonomous zone is right here. Thumb first web space, right here, not here. Lateral antebrachiocutaneous nerve, not here, which can be C7, and sometimes even median nerve can come up onto the back of the fingers. But there is no other nerve that innervates this other than the radial sensory nerve, C6. C7, and another way to think of this, 5, 6, as in 6-shooter. All right, 6 characteristically goes to thumb and index finger. 7, middle finger. 8, ring and small. And then 1, the medial border of the forearm. Okay, so pure autonomous zone, 6, but 6 does go out to the tips of the thumb and index. 7, autonomous zone is middle finger. 8, small and ring, and then 1, medial border. Fine level of sensory exam. What I did was light touch examination by looking at each of the autonomous zones. If we're going to look at fine level losses of sensibility, you need to have a 2-point discriminator. These are sold, but you can make one out of a paper clip. What's important is you determine the ability of a patient to discriminate between 2 points. And this is called static 2-point. You can do a poor man's rolling or moving 2-point by simply dragging the 2 tips along the finger and seeing if they can better perceive the distance between 2 points if it's moving than when it's static. So let's begin by looking at the hand. In a person who's complaining of numbness in their thumb through middle fingers, you'd think about carpal tunnel syndrome. You would then go ahead and compare the median innervated digits to the ulnar innervated digits. Median innervated digits, obviously thumb, index, middle, and half of the ring. Ulnar innervated digits, little, and the other half of the ring. So you can take your 2-point discriminator. You want the patient to look at it, let them know that these are dull tipped, they're not going to hurt them, and stabilize the hand so that the person doesn't pull away, usually on their lap. Now, what I'm going to do is I'm going to ask you whether you feel 2 points like that or 1 point like that. Feel the difference? What you're doing is applying just enough pressure to have the skin blanch. All right? So we're going to start with a fairly widely disparate spacing of 2 points. In this case, we're looking at 8 millimeters and comparing it to her ability to perceive 1. We're then going to either block her from visualizing it or ask her to close her eyes and do the same thing. And you're going to move around fingers, and you're going to move around amounts, and you're going to go fairly rapidly. And I want to hear from you whether you feel 1 point or 2.
2. 1. 1.
And you just move around, and you try to maintain all that in your head as you go, whether you've touched with 2 or 1, and try to come up with a clear reading on what the closest distance that she can perceive accurately, say 3 out of 4 times. Normal is anywhere below 5. Pianists and other people that use their fingers for livelihood, jewelers, those sorts of things, those sorts of occupations, will show 2-point discrimination in the 3 to 4 millimeter area on static, and sometimes down to 2 millimeters moving. Normal, again, is considered 5. When you start seeing 6 or 7, that's diminished 2-point. 8 and above would be a very serious loss of 2-point, and sometimes patients are 15 or 20, indicating essentially complete anesthesia. C5, biceps. If the patient's having trouble relaxing and you're not getting a good bicep exam, you ask them to flex fist on the opposite side. So go ahead and make a fist on the opposite side. Takes their mind off it, allows you to get a better C5 exam. Okay, relax. C6 now, right over the brachioradialis. Okay, we're seeing a very brisk brachioradialis reflex, but I'm not only looking at the amount of reflex seen here at the elbow, but also looking at the fingers. If the fingers were to contract during the examination of C6, and we're getting addition of further levels and finger flexion, that's a pathologic reflex. So you want to be aware of that and look for that. For C7, triceps, I'm going to ask the patient to raise their arm up and let the elbow just relax. You can both visually see the triceps contracting and a slight extension of the arm. You can obviously compare right versus left and be sure that you've done both normal and then pathologic reflexes. Hoffman's exam, when you're flicking the thumbnail, you're looking to see again if other finger flexors are contracting. So reverse radial reflexes I showed before, Hoffman's examination, those are pathologic reflexes of the upper extremity and indicate potential cord entrapment or higher up.